Started. Thank you all for joining. Welcome to our webinar today on screening for the SDOH for the social determinants of health among persons with HIV webinar. And this webinar is brought to you by the National Center for Health in Public Housing. So this is just some background information about the National Center for Health in Public Housing. The content of this learning collaborative is 100% financed by the Health Resources and Services Administration and do not necessarily represent the official views of HRSA, HHS, or the U.S. government. The mission of the National Center for Health in Public Housing is to strengthen the capacity of federally qualified health centers and other health center grantees by providing training and technical assistance. So this is just a preview from today's speakers. So today we will be hearing from Dr. Kevin Lombardi, who is the Director of Research at NCHPH, and I will be also co-moderating. My name is Fide Pineda Sandoval, and I am the Training and Technical Assistance Manager here at NCHPH. And we have Dr. Kevin Lombardi in the line. Thank you. This is just a quick reminder to everyone that all participants are muted upon entry. Please make sure to engage in the chat and raise your hand if you would like for your line to be unmuted. This webinar is also being recorded, and the slides and recording link will be sent via email shortly after today's session. Additionally, we'd like to know more about you, so let us know in the chat your name, your title, and where you're joining us from today, and what are some of the top things that you're looking to learn today during our webinar. Thank you. All right, so here we have some information about public housing, primary care health centers, and in public housing developments. So as of 2023 UDS data, there were 31.2 million patients that were seen at FQHCs. Also, 475 FQHCs were near public housing, serving to 6.5 million patients, and 107 PHPCs that serve to over 900,000 patients. And here we have a map that is also provided by NCHPH, which you can access on our website at nchph.org. And here we have some demographics information based on UDS 2023. So as of 2023, 76.36% of PHPC patients were below federal poverty level. 58.15% were female, 29% were children, and 10% were elderly, and 18% were also uninsured. So here we also have some public housing residence demographics data, which you can also review on your own at the HUD Picture of Subsidized Adults publication. And now, without further ado, I'll pass it on to Dr. Kevin Lombardi to continue with the webinar.
I got my mute first time today. So glad to see everyone. First of all, thank you for your service to your communities. I've seen we have a lot of medical case managers. You guys really do the most critical and important work for our patients. Thank you for your service. I see we got some Zoo Fall people here. Your current director is an incredible woman, by the way. Incredible health center. Wow. Put your stuff in, guys. In many cases, we know the people that work with you and would love to see some more. Also, let's set some expectations. I'm speaking to you as a colleague today. My name is Dr. Kevin Lombardi. I'm a medical doctor and epidemiologist. My training is internal medicine, and I've seen HIV patients for years in the primary care and the ICU realm. As a public health manager, I started a large primary care system in Haiti that serves HIV patients. And I've got to say, from a point of sincere humility, that serving HIV patients and people who have HIV has been one of the most astounding privileges of my career. these folks teach me so much about the condition and how they live their lives to live healthy lives. And I'd like to pass some of that to you and also bring you into the conversation as well. So let's do this, Fide. Let's get to work. Next slide, please. Okay, so I have a system here. So we're going to be going over this from a variety of different perspectives. Here they are here. My goal for you is to understand what's out there as far as screening tools, what's good, why I like it, why I don't like it, my opinions on these from a clinical perspective, and also some thoughts on how to implement this in patient care and some things to keep in mind with leveraging partnerships to make sure you have the appropriate SDOH ecosystem to support your screening efforts. And finally, we're going to go over some short case studies and put this stuff to practice. Next slide, please. And skip that one. That's just because I was really enjoying the clip art that day. Okay, so first I want to direct you guys to one of my publications on this subject, Screening for SDOH and Social Risk Factors in Patients with HIV. It has many of the resources we'll be looking over today and my review of the latest and greatest out there and how it works and how it doesn't. My recommendations to you. Next slide. So let's start by talking about epidemiology here, and let me pull up my slides. So what I have for you here is a really incredible thing called the AHEAD dashboard. Now you can follow that link to the bottom, which I recommend you clicking right as soon as you get these slides and taking a look, and you can look at up-to-date HIV information, incidence, knowledge of status, diagnoses. These are all major benchmark for us. And you can go ahead and break it down by your geographical location, race, ethnicity, age group, any demographics that are important for you. For those of you who are managing cases, writing grants, or program developing, these are the kind of tools that can give you important data to cite in your applications, in what you write, and can orient you to what the issues are in your community. So when we're talking about HIV and SDOH specifically, research has consistently indicated that providing non-medical support and for those who have HIV, those who are at risk of HIV, such as IV drug users, etc., leads to better health outcomes, period. The research is overwhelming. Changing in housing status specifically has been shown to significantly reduce risk behaviors associated with HIV, such as drug use, etc. And one of our major tools to support HIV patients is those SDOH supports. It's funny, when I was training, I worked with some internal medicine physicians who were there in the beginning days when they were first discovering this condition in the communities that affected people. And I have personally seen many patients with end-stage HIV just walk out of the cane fields in Haiti who have never seen a doctor. So this condition, when it's not managed appropriately, can be life-shattering. But when we use the resources we have, up-to-date antiretroviral therapy and social supports, we give our patients the ability to and empower them to live with this as a chronic disease. And that's an amazing thing that we've been able to provide really just in the last generation or so. And social determinants of health is how you make sure that those patients have the support they need to take their medicines, their very complicated medicines, on time and appropriately. Next slide. It's our key to adherence. So let's briefly go over the tools, sort of orient ourselves. And for me, the first SDOH tool that I experienced was the Prepare School tool. It's very standard. It looks over multiple different domains and gives you some key information that's very important for your screen. The Prepare is kind of the standard use, and for those of you who are just starting, it's the good one. It's a good one to start with. What I will say is the data does also tell us that health centers should feel free to add questions to the Prepare and other screeners when appropriate. Now, for those of you who are specifically in, say, rural areas and may have some more transportation questions you want to ask, in addition to what Prepare has to more accurately direct people to your programs, do it. The Prepare and the SDOH screen in the hands of a CHW is a roadmap to success. And that success is on the map is different SDOH supports. The screen is what directs patients and allows you to direct patients to specific resources. And if you look at your resources, look what's available, what are you referring patients to, and look at the screen that you're using. If there are other questions that may capture that, the evidence says that it's within your power to do that, and you should do that. Next slide. Now, the Prepare will be our counterfactual, and we'll look at and contrast some others. So here I have, and you will be getting the slides. This is designed to be a consulting style document. So I'd encourage you to get the slides, get the bottom, and take a look at these things yourself. They are all public access. And I would encourage you, if you're thinking about SDOH screening, first look at all available tools before you do it. Second, if you're already doing SDOH screening and you think there might be a way to improve or optimize your system, look at the things that are available. Just seeing how they phrase the different questions and how that may be effective in your community is very important, because remember, you are the expert on your community. So these are national tools kept with a national audience in mind. So the upstream risk screening tool guide is designed to help healthcare providers identify the social determinants affecting patient health, period. The key features that differentiate it a bit from the Prepared is, one, it's very comprehensive. It looks at 14 social determinants of health across the 5 domains. It's structured along 28 questions, so it's a little longer, and you should be able. This is good for a circumstance where patients have more time to fill out the form, perhaps with a CHW home visit or the like. There's a scoring system, and the scoring system then provides recommendations as well. I'd recommend it more for a home visit setting, but it may be appropriate for other clinical settings where patients have the time to fill out the whole questionnaire. My recommendation would be first-time primary care clinic appointments, and in the hospital via social work when you have a patient that's transitioning to outpatient setting. So let's look at another one. Yeah, so this one is fun. This is your current life situation, and like these tools, and remember, we are in the clinical realm and in the social management realm. We are artists, and these are our tools, and we are limited to the extent of the language and the screening tools. So it's very important to orient yourself on what they do and what some of the advantages are. What I like about your current life form is it's more personalized. It provides more personalized care planning because of the more specific social and economic questions, specifically about economic challenges and the tailoring of interventions. It facilitates into community health worker and social worker workflow efficiently and effectively, and it can be easily put into a medical records form because of how the questions are asked. So those are our screens. I don't have a favorite overall. My recommendations are based on just experience, my own preference, and so forth. I strongly recommend that you look at all available tools before making a choice, and that you have an interdisciplinary conversation with your colleagues about that. How your community prefers to be communicated to will come out. Next slide, please. So when do we do these things? Social determinants of health, right? When do we screen? There are a variety of different contexts where this is appropriate, and I want to focus first on the primary care realm. When your patient is doing an intake, have them do an SDOH screen. Have the nurse put it into the medical records system. When the physician or advanced provider has access to that information, they can trigger social services and trigger referrals. Now, if you have a different system where a case manager views these things separately, then EHR is even more important because it needs to get them as well. So my recommendation, based on analysis of clinical evidence, is one, making sure that you're doing that in the primary care realm for new and existing patients. New and existing patients. Two, ensuring that when there is that follow-up engagement, when a patient is sent to social service or has a structured social service or social CHW follow-up, there should be an additional screener. That is a second baseline. The CHW will be able to compare that to the existing screener, and sometimes discrepancies tell us, one, a change in the patient's condition, or two, a change in how they're reporting things, all very important for a clinical assessment and appropriation of resources for these patients. Next slide, please. And my recommendation is to use the CHW coaching style system. When a patient is flagged in the primary care realm, or in the inpatient setting, if your system has CHWs available, it allows the more engineered resource allocation. CHWs are able to do an intake and provide a coaching style assessment that gives patients more direct attention and care. And the structured follow-up makes sure that those patients have the support to get those resources as needed. When you see a patient and you throw 100 resources at them, it can be overwhelming. CHWs allow patients to digest it, and they are able to interpret and communicate to the patients in a way that is appropriate for them. This is the best system for these folks with HIV because of the complexity of the condition. Especially if we're considering patients with new diagnosis, managing HIV care is overwhelming. It's overwhelmingly complex. There's different referrals, different physicians, there's new medications, there's a new routine to it. And a CHW coach can provide the support and the allocation of resources in a way that's appropriate for those patients. I strongly recommend this system, and the evidence does too. Next slide, please. So I've spoken a couple of times about the importance of EHR integration. And I'll say that because when I first started this, we were doing this on paper, and it was going to the doctor's, the clinic room with the patient, with the other paperwork, and it was not integrated into the EHR, and things were missed. EHR is the best way to make sure this data is held. Also, keep in mind that when it's in the EHR, it's in stone, and it's there. So social workers, case managers, intern physicians will find this stuff, and they will look at it, and it will impact patient care. I cannot tell you how many times when I was in residency that I would refer to this information when thinking about outpatient care. And they were key parts of my assessment. And that's just one perspective. So when this stuff's in the EHR, it's there and it can be referred to, and it can allow us to help the patient in times when the patient may not be able to speak, may not have someone there with them. So please make sure that if you can, put it into your EHR system. Now, that's an easier said than done, right? You don't just click a button and get it. There's many buttons to click. But the key things to sort of drive the argument forward are, one, the standardization of SDOH data collection. This allows your case managers, social workers, on the ground social support personnel to make sure the data is getting to everyone in a language they can understand. And it's as simple as this. The form is translated into the ER, and the questions are put in the coding specifically to your EHR. Every facility is going to have a different way that you do that. If your primary care center is attached to a hospital, it's going to be more complicated. But for those of you who don't have SDOH screeners in place at the moment, talking to your EHR provider about how to get new forms on and how to make sure the data is going to the medical record appropriately is a necessary but complex part of the process. So talk to your IT person. So other things to push forward is that getting it into the EHR increases the functionality of the SDOH documentation. People can look back and see years of this stuff. They can structure a patient's care more longitudinally and give more personalized care to SDOH services. So strong recommend. Also, when we're talking about putting a SDOH screener in, there's a training implement that needs to be integrated as well. There should be an email blast to everyone showing that the EHR is doing this. Regular reminders that the SDOH screener is used in certain circumstances. And for frontline personnel who are doing it, your LPNs, your nurses, your community nurses, community health workers, social workers, those who are providing these assessments, assessments to the patients, need to get training on how to do it, how to give it to the patient, how to proctor the tool. What I will say is each of the tools that I've showed you have an implementation guide that you should follow when you choose what you're going to use. Next slide, please. Okay, Fide, so we're going to spend some time. Say hi to the crowd, Fide.
Hi everyone. I'm still here, just in case.
And we're going to pull our audience in and talk about some of the recommendations here. And this is from the Center for Innovation and Engagement. It's the implementation guide for evidence-informed approaches for people living with HIV. And it spends a lot of time going over SDOH assessments. And we're going to kind of switch from screening and now talk to about the assessments, with what the patients get. So Fide, I'm going to throw some bullet points at you, and you're going to tell me why you think it's important for a patient with HIV. Okay. So let's start with telemedicine. One of the recommendations for the report was that integration of telemedicine is critical for patients with HIV, and that's telemedicine not just for their. Oh, I see him in the shadows here. That's telemedicine for everything. So social services as well. So considering this, what I just said, why do you think this would be important for that patient on the ground, that person who needs to get their care? What might be helpful about telemedicine appointments for them?
Yeah, no, absolutely. I think telemedicine just overall helps increase access to HIV services, especially in underserved areas, such as rural areas here in the US, and just anywhere around the world. And then it also, for patients that may be experiencing stigma related to HIV, they'd be more, I want to say, prone to actually going to a telemedicine or telehealth visit. So those are two things. It increases access to care and also helps reduce stigma.
I want to pause you before you keep going. So you mentioned a couple of things. First, rural areas, right? And telemedicine for a person with HIV is, when I'm thinking about someone in a rural area, it emphasizes really the importance of that, because I'm thinking about all the referrals that the patient is going to have. I did my training in a rural area, and it was really difficult to get specialist care for our patients that didn't require an hour-and-a-half drive. Now, I don't think I need to tell a lot of our case managers what the barrier is for that, especially in rural areas. So that's a long drive. Folks just couldn't go to their appointments. And a word comes to mind as well: stigma. First, we'll throw that to the crowd. Does anything come to mind for folks when they think of stigma and telemedicine, of the importance of it? Hands if you got them.
Yep, you may raise your hand. I'm sorry. Kind of clicked the wrong button there. Yeah, you may raise your hand, and definitely we also encourage you to provide any responses that you may have or feedback in the chat. what pops up into your minds about stigma?
So I'll refer to hands. Folks, put your hands up if you'd like to join us. We'll pull you into the conversation or toss it into the comments. So when I'm thinking about patients, specifically those with HIV diagnoses, stigma is a commonly reported barrier for patients going to their appointments. If we think about small communities, that might be even more. Sometimes folks in rural communities prefer to get their HIV care out of their communities because of the concern of stigma. And being able to provide that sort of service provides them protection. And that's something that's very popular for patients with HIV. And it's popular enough that some folks prefer that and may not get care if they don't have that. So making sure that resource is available, and specifically that someone in the social services is talking about them, is a key driver of patient compliance. And when we're talking about HIV, compliance is life-saving. Compliance saves lives. We want to keep those viral loads as low as possible, undetectable. And making sure telemedicine is available is an appropriate and excellent recommendation. Let's pull another one up. And, Fide, they mentioned something here about integrating behavioral health services. So we know that behavioral health services are important for all patients, but for folks with HIV, there are common co-diagnoses of depression and major depression, anxiety, and other conditions. And if one considers the social stress that the stress that HIV puts on the patient, mental health diagnosis and mental health support is very important for supporting these patients. Do we have any mental health providers in the audience? Hands, please. No providers, Fide?
No, nobody has mentioned anything just yet. Oh, Ashley mentioned we have co-located mental health at University of Iowa.
Ashley, do you want to jump on and tell us a little bit about your system? I'm curious to hear. And Ashley, if you could please introduce yourself and tell us who you serve and how.
Can you guys hear me?
Yeah, we can hear
There
you
it
now.
is. Hey,
Thank you.
sorry. My name's Ashley Brennan. I'm a admin services coordinator for the Ryan White program at the University of Iowa. And we have, in the last couple years, had 2 providers join our team for 1 day a week. We have most of our clients on a specific clinic day. And so we have offered the opportunity to our patients to see someone in the same clinic that has a day a week where they only see HIV patients. And we've seen that be extremely beneficial for a lot of our clients and patients, simply because these providers are also dealing with other people that are dealing with the anxiety, depression, as well as HIV.
Well, that's incredible.
That's really cool.
That's the kind of program that puts a smile on your face. So and you can imagine someone in that circumstance needing that care and that care being there for you. I've got to ask you, Ashley, do you think this has helped uptake of are people more willing to accept the care? Are they actually following through with the mental health care? Are you seeing more uptake of this resource?
I would say so. We have at least in our area in Iowa, we have some limited availability to get in and see these kinds of providers. And these providers are not only providing therapeutic services, but they're also able to prescribe medications for our patients. So we tend to do very quick referrals to them. We can also have patients that come in, some sort of a crisis, that are able to meet with someone that same day, whether that be those providers on our clinic day or the BHC on our team, that takes time out of her day to handle those situations. But I think in general, we are able to see those patients quicker, which also they see that as it's a positive resource because they're not having to wait and kind of have the chance to change their mind about getting care, I think is part of it.
Mhm.
Yeah, I'm considering this, and first of all, I'm thinking, well, the data shows us that those crisis opportunities, you don't get them back. You don't get those opportunities to intervene when someone really needs you. And those are making sure folks get those services quickly and appropriately is literally life-saving. Literally life-saving. And the other thing that comes in mind is the barriers of stigma. Sometimes folks won't see their mental health provider. You can refer them as much as you want, and it's very difficult to force some folks in there. When you have someone there who's able to respond very quickly, what the data shows us is those co-location services do get people to use their resources more likely. And when we're talking about folks with HIV, the data also tells us that they're more likely to be compliant with their antiretrovirals, and that's our goal, to keep that level undetectable, keep them healthy, and keep them happy. So thank you for sharing, Ashley, and you guys are doing incredible work. Keep it up.
Thank you.
So, and I do want to I know I've said this a couple times, but when you're thinking social support of folks with HIV, making a key driver, a key metric that you should be pushing for is how quickly that the patient's going to get on their antiretroviral therapy. Again, an advantage of telemedicine and an advantage of mental health is sometimes there are mental health barriers that are preventing patients from being adherent, and addressing those barriers early on supercharges that care and supercharges that patient's ability to take the medication as prescribed. And so I'm going to pull up another recommendation that I really liked. I've been reading the research on this for years, and I just think it's a great intervention. Peer navigators. So one of the primary recommendations was establishing peer navigation programs to assist patients in navigating the healthcare system. Now, if I could get hands on why this is specifically appropriate as a recommendation for these patients. Let's get a hand, or I'm gonna sacrifice Fide on this one. So Fide,
Mhm.
tell me, peer navigation systems, why would they be important for someone who's dealing with a new diagnosis like HIV?
Well, at least from what I can think of is, it would help it will help how to process or navigate the healthcare system. And in this case, maybe like a community health center. Somebody who's dedicated to that process of helping an HIV patient with
Well,
their
you know what, you're right,
therapy.
Fide, and let me ask you, if I just gave you a new diagnosis and you need to do 100 different things as soon as you just found out, uh, are you going to be overwhelmed by that?
Absolutely. Yeah. Yeah.
Yeah, and I'll tell you, before I sink the hole on this, sink it in the hole. I'm gonna say, Leslie, do you want to share a thought about that? Because I think you're right. I want to hear it from
Let
the
me
horse's mouth.
yeah, there you go. Oh, just unmuted her line. There you go. Yeah.
Leslie, please tell us who you serve and how you serve them. And thank you.
Hello, I'm a case manager at Priority Healthcare, assisting our clients living with HIV, and having a peer for them has actually one of my clients, she does speaking engagements, but she really liked having a peer from when she was first diagnosed. They helped her understand the documents and what was going to happen next, and gave her different tips and tricks about how to care for themselves living with this new experience.
Yeah, Leslie, I'm thinking about that experience and how much have you does this help patients navigate those things, and like how does it help them? Because I hear what you're saying.
It does, because everyone
I'll
likes to talk to
question.
someone that they have a shared experience with. It makes them more comfortable. And me being a case manager, they can like me, but to say that they have a shared experience with someone else who may have been, having HIV longer, and, some people still think it's a death sentence, but to see people who have 20 years, 30 years living with HIV, they're doing fine, they're employed, they are in meaningful relationships. It really changes mindsets.
I love that. You just hit the target with that. The good that these programs can bring to people, it's incredible. And when you were mentioning specifically that peer relation, that mentor relationship, folks who have lived through this, they're experts on running this system. They know where to go, the best providers to go. They can give you personal experience. And I'll tell you this, Leslie, when it's me talking to the patient or one of the peer navigators or your colleagues, who are they going to listen to, me or the peer navigator?
That peer navigator.
They listen to the peer navigator.
Every time.
And I wanted to say that to get the point across that we are all colleagues here, and what social services and what peer navigators and what family members and everyone with that information is doing is they are supporting you in the clinic room. So, go with some humility when you understand that, and speak to your social service colleagues. And I will say, thank you for your service to your community, Leslie, and thank you for sharing with us.
Thank you.
I'll go over a couple more quickly, and then I want to do some case studies because I want to get as close as we can to these patients and their clinical lives. Housing interventions. If you were to ask me, Dr. Lombardi, what's the evidence say? If I just needed to pick one intervention and I only had one, what would it be? And I would say, the argument I would give you is for housing intervention. It is very challenging to manage an HIV diagnosis. It's very challenging, even with support. It's incredibly challenging. And I'd like you all to think of how difficult that could be if you didn't have a home or a stable home. It makes it much more challenging, and housing supports are according to the evidence, the best thing we can give a patient to support them in their HIV. And what the outcomes are that those studies have looked at is specifically time to antiretroviral treatment and time to undetectable viral load. If you can get a patient into a house, you're making it a lot easier for that patient to get their viral load down to undetectable. You're making it a lot easier for that patient to manage this chronic disease. So I just want to get that point across as much as I can, because frankly, we're the National Center for Health and Public Housing. And if you didn't expect that pitch, you're in the wrong webinar. Housing is critical and important. I do also want to get the transportation assistance across too. Regardless of the patient, if they are in a rural area, it's often very difficult to assess to get to a health center. Sometimes this can be a 45-minute drive. Folks don't have transportation. In urban areas, it can be difficult for different reasons. Sometimes there's safety concerns, so on and so forth. So transportation supports are cited as being a key social determinant of health support for these patients. And I would recommend that you have systems specifically for this patient population to pick up, because it will lead to better compliance with recommendations, more likely the patient is compliant with antiretroviral therapy, and that gets us closer to getting that viral load down to undetectable. And we owe that to our patients. Let's get into some case studies, Fide. Next slide.
Yep.
Okay, I'll read the first one. So, we have a 45-year-old male patient living with HIV who presents to the primary care clinic for routine follow-up. Despite adherence to antiretroviral therapy, his viral load remains detectable and reports frequent missed appointments. During a structured SDOH screening, using the Prepare tool, the team identifies significant social risk factors, including unstable housing, food insecurity, and transportation barriers. So you got this guy, 45 years old, has the condition, his viral load is detectable. He says he's taking his medication, but he's missing appointments. These are red flags. SDOH fact, and when we think of these red flags, when we look at the SDOH screen, it has a couple of main things that we know are associated with lower uptake of antiretrovirals. This is the sort of patient story that should make a red flag go up in your mind. Bing. Next slide. And I want specific interventions here, no just transportation. What do we do for this patient at this time? He's filled up the SDOH questionnaire, told us we have transportation issues and so forth. What do we do? Let's go back to the case slide for a second. And now we'll start. Give it a second, folks. Raise your hand. Teach me something. Tell me something here. Or we'll sacrifice Fide to the lions again. And
don't let that happen, please.
We have a great working relationship, guys. It may not seem like
We like to add a little bit of humor.
What do you do? This person needs specific things. What do we do?
Yeah, or also just share with us, like what you've been doing, at your health center. How are some of the things? Promising practices. Yeah.
Okay, Fide, I'll start with one. So if I'm looking at housing instability, most health centers have a relationship with their housing office. Oftentimes, patients with HIV are prioritized for housing because of the importance to their clinical condition, and that differs from municipality to municipality or state to state, but it's something that may be available in your area, and these patients could be networked very quickly. So that is sometimes insurmountable for other patients, and it may be easier in this circumstance. So that tells me, one, the importance of having that relationship with the housing administration. There's one in your area, know them, and they want to know you. You guys are a match made in heaven, and you don't even know it yet. Know your housing organization, because they are fantastic and reliable partners. And if your housing organization, did you know that health centers are fantastic and reliable partners? Meet each other, know each other. Michelle, I'm seeing address food, sir, and connect to. Okay, you get some things here related to these. Are you able to join and tell us what your thoughts are?
Hi, good afternoon. I don't directly work with providing case management services anymore, but it was something that I used to do. So the approach listed here is how we would approach helping someone who really seemed to be in need of our support.
Mm-hmm. So when you're thinking of food insecurity, how do you think that if you're dealing with HIV and food insecurity, how do you think that makes adherence difficult for you? And it's okay if you don't know. I'm putting you on the spot a little bit here, but can you think of anything?
Oh, I mean, Doc, it'll be very difficult for anyone to be compliant, in achieving the HIV outcomes when they are in need of some housing, in need of some assistance to get to even to get to their appointments, and they need housing. It'll be really difficult for someone to fulfill so many of their own care when they have so many additional needs.
100%. And you said it as good as anyone would. Thank you very much. It is, when I hear that, and I'm asking you because, Michelle, we're in the clinic. We don't know this stuff sometimes. We don't know how patients are living their lives. We're going from diagnosis to diagnosis and thinking about it in a medical sense. And we rely on our colleagues like you in the social services realm to be able to tell us these things. And what I hear from you and what I hear from my other colleagues, it seems unreasonable to expect someone to be adherent to complex medical therapy when they are having difficulty feeding themselves. Unreasonable.
Yes, Dr.
Thank you so much for serving the way you serve and for sharing with us. Fide, what do you think? Do you agree?
Oh, absolutely. Yeah. It's
a
very
big
true.
deal.
Yeah, it
It's
is
a
a big
big
deal.
deal.
Mhm. And
Considering no, go. It's you.
no, go ahead. Go ahead.
I'm considering that individual. I've met that individual before, and I've given those diagnoses, and that is not an easy conversation to have. Being on the other end of the conversation is traumatic, to be honest. Imagine being that other person. And imagine dealing with those challenges already, because you went into the clinic with those. You went into the clinic with the housing insecurity. You went in the clinic with the food insecurity. And those are pretty complex things to keep up with. This person may be unhoused and may need to daily search for a new place to sleep. They may need to daily look for new places to get food. That's incredibly challenging. And now, boop, you've got to manage this complex condition.
Dr.
It's
Kevin,
unreasonable.
Dr. Kevin, I'm sorry, so sorry to interject, but
Let's
I
hear
know
it.
in some states, I know Medicaid is starting to pay for individuals in need of some kind of extra social support. And I think it might be good for anyone working in the clinic to know if somebody has Medicaid, how can Medicaid support some of these food insecurity issues and transportation issues that they bring for us to address.
I couldn't agree more, and thank you so much for sharing. And I'd like to emphasize that, and add a statement to it. Is one, you're 100% right. And when I think of who knows these things, it's the case managers, it's the CHWs, it's the social workers. And based on wherever you are in your state, in your location in the United States, there will be that, and there will be other resources, things that come to mind specific to the patients. Know your economy of resources, know the things that are available for the patients, and know how to connect them. And I'll thank you for that. And ask that Fide goes to the next slide. Okay, and next one after that. We're jumping. So here's what we do. Case manager connects the patient with a local housing assistant program, enrolls him in a food pantry service, and arranges transportation vouchers for medical visits. And now, that's just a sentence, but behind that is a whole structure of protocols that a case manager followed to get that person to those things. And that requires certain thinking behind it. SDOH screeners are like any screeners, and that you don't ask the questions if you don't have the resources. do not send SDOH, do not have folks sign these forms, fill out these forms if you do not have resources for them. It is unethical. But I know that the health centers that have implemented these programs do it at the highest level of integrity, and they often have extensively detailed social systems and social networks that provide these right resources. But it's a lot of time behind that. Knowing your resources, knowing your environment, and the important thing, knowing what partnerships you can pursue and expand. You'd be surprised what might be in your ecosystem. Next slide, please. Okay, so Fide, or anyone, this is to the crowd. The patient got some support. His viral load is undetectable. Are we done with him? What additional resources do we need now? Do we need anything? Are we done?
I would say we're not done because we still want to make sure that the patient maintains that same viral load undetectable for the longest period of time possible. So we want to make sure that he's following up on the treatment that he needs to be following up, continuing accessing the support services that is needed.
Well, you're 100% right. And Michelle just said, Michelle, why is this still your patient? The viral load is undetectable. We fixed it, right?
I'm gonna piggyback on what Fide said. He's still our patient. We need to ensure that all of the social determinants of health needs that the patient has, that we continue to address them, and we continue to be a support system for him and maybe his family members as well. Our job is not over because our patient has achieved viral load suppression.
Out of the park, 100%. But I can't tell you how often, when we look at these medical records, we see undetectable, and we think of it as solved. And I can't tell you how often I hear that. I can't tell you how often I see that. And it's very encouraging to hear your analysis because you're 100% right. These patients need longitudinal support. Just because their viral load is undetectable does not mean that condition got any easier for the patient to manage. It's not something you just achieve and then is achieved. It requires resilience, it requires persistence, and it requires that social support. A patient like this, if I got my wish list, would see a CHW at least every 6 months, and I'd get it. Because this is appropriate medical care for this patient. This is a patient who should have a 6-month follow-up with me, even if they're undetectable, in addition to their ID doctor as needed. And 100%, we need to continue to work together in an interdisciplinary team to make sure this patient viral load is undetectable. And I will say, for those of you who have worked with ID physicians, they take this very seriously. And they're great interdisciplinary partners. So if you haven't pulled the patient's ID doc into your care team, give their office a call, because they may be able to make things easier for you, and you may be able to make these things easier for me. And when I think of networks, pull your ID office, your local ID office, because they're the ones that are prescribing the antiretroviral therapy. If I have a patient with HIV, I'm managing their chronic diseases, is why the other doctor is doing that, and I'm keeping an eye on it. Bringing that interdisciplinary team together and making sure your case managers have access to these individuals pulls things tighter. And with patients that are undetectable, they may not be undetectable forever. So you need to be able to know this information and amp up those supports when necessary. And this is all part of the case management for HIV, which is why it's so interesting, is it is so complex. Next slide, please. Okay, here we're going to talk about program management. We have a federally qualified health center serving a predominantly low-income urban population, would like to integrate routine SDOH screening into its EHR. Good, smart. That's following the research. This is great. Next slide. Let's see how they do this. Okay, so first, let's talk about, and I'm going to teach this instead of asking it because of the time, but what steps can a program managers make to ensure the SDOH screener is implemented effectively? And what I'll say is you need to do an analysis before you start an SDOH screen. You cannot just start asking it until you know your resources and you know what patients are going to ask for. So typically what will be done is a pilot study where resources will be arranged in the domains. A health center will look at all of its different resources, compile them, have protocols for folks to refer them, and pilot an SDOH screen. Oftentimes, they will have added their own questions already if they need to tailor that, and then do an initial study where they assess the implementation. That's recommended in these circumstances. Also, making sure that your social network, and when I say social network, I mean social referral network, is tight. Know the partnerships in your area that might be able to provide SDOH services. Look at the 5 different domains: housing, food insecurity, economics, and so forth, and reach out to the partners that might be helpful in your community. I would like to say, do not sleep on faith organizations. They can often provide transportation and other resources and peer support resources. Do not sleep on your local housing organization because they can provide, in addition to housing services, other services to the patients. And if your health center is associated with a larger health network, hospital network, and so forth, there may be additional resources in the social services realm that are available inpatient that are not available outpatient. Talk to folks. Often these are different case managers, and often they have different resources. Share notes. Next slide, please. The health center decides to use the Prepare tool and provides and that screens all the patients during intake and annual visits. That's the recommendations. Their implementation research indicates high risk of housing instability, unemployment, and food insecurity. So they did their pilot, and these were the most common SDOH constraints that folks mentioned. Next slide. And our next step is to focus on our partnerships. When you are building an SDOH program, you don't just build it and leave it, right? You should be continually reassessing the social supports that you have available in your network and assessing which new ones might be available. Things are changing constantly. Talk to your partners regularly. I know when I'm doing this sort of work and I'm working with other organizations, sometimes I'll just get on the phone with my colleague in the other organization just to share notes on things or just to talk about things. I want to emphasize how important the relationship you have with a colleague or a partner is to someone's HIV care, because that's how the resources get there. So have those conversations, have coffee, do something, but talk to your partners and build that relationship as much as possible, because through those conversations, you can find new ways that your organizations can support each other and support your patients. Next slide, please. So in response, the health center creates a referral network. And that's where I'm going to mute myself and I'll say, I'm Dr. Kevin Lombardi, and there are a few people I like more other than health center employees. So please reach out to me if there's anything I can do to help support you or your staff. And I'll give things to Fide. Thank you.
Thank you. Thank you so much, Dr. Kevin Lombardi, and thank you to the participants that also participated with us and engaged during our exercises. We hope that you were able to find this information useful. If you have any follow-up questions, please make sure that you reach out to us via email at kevin.lombardi@mgt.com. And also, this is just a reminder to everyone to please complete our post-evaluation survey and let us know in there also what are some other topics that you would like to learn about in our future trainings. And please visit our website at nchph.org to access our latest publications, webinars, learning collaboratives, and more. And here is our contact information. You may also reach out to me at fide@mgt.com if you have any other questions. Thank you and have a great rest of your day. Goodbye. See you next time.
Thank you for serving our patients and your communities. Bye, everyone.